right. Hello, everyone, and welcome to today's session on combating stress endured by first responders of organ donation. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to be here today to kick off the discussion. Now, today we will be examining the unique stressors that impact our frontline heroes, and we'll share effective practices to overcome those stressors. In just a few moments, I'll be turning the floor over to our moderator and panel, but before I do, I'd just like to remind everyone to take advantage of the chat feature. If you have any questions or comments that you'd like to add to the discussion, please feel free to submit them at any time. If you happen to have submitted questions during the registration process, we'll do our best to address them over the course of the discussion as well as during our open Q&A period. That said, should you have any additional questions, please feel free to submit them using that chat box. Now, as a friendly reminder, there'll be no continuing education credits offered for today's program, but certainly you'll still have an opportunity to claim a certificate of attendance and provide us with your feedback through the post-event evaluation. An email with detailed instructions on how to do so will be sent to all of you following the conclusion of today's discussion. As always, today's session will be recorded and made available on demand for your convenience. You'll find the recording on our website at organdonationalliance.org following the conclusion of the program. Now, lastly, for anyone who's joining us as a group today, I'd like to ask that you take note of the following poll and complete the poll to share approximately how many people have joined your group. Now, with that, I'd like to go ahead and begin today's program by welcoming back our much valued moderator, Candy Wells, who serves as the Director of Organ Utilization at Life Center Northwest. Candy, it's so great to have you with us again today. I'll leave it to you to go ahead and get started.
Great. Thank you, Tana. I am privileged to introduce Sue Johnston and two of her colleagues that will be working with her to contribute to this really important conversation. And that's Maren Bloomberg and Amy McDonough. And Sue Johnston brings 30 years of experience as a psychotherapist treating medical professionals and first responders experiencing work-related stress and psychological trauma. She has personally tested her evidence-based, practical, solution-focused resilience and stress management strategies as a responder to multiple mass casualty events, while she's worked for Doctors Without Borders, MSF, and working in a war zone in Myanmar. Through her partnership with LifeSource in Minneapolis, she's had the opportunity to shadow OPO staff, work through the process of procurement, and has seen the work through the eyes of the frontline staff, which is such an important piece of being able to have this conversation today that really relates to those of us in this industry. Maren is actually an organ donation coordinator at LifeSource. She attended the University of South Dakota and graduated with her Bachelor's of Science in Nursing in 2016. She moved to Minneapolis and began working at Abbott Northwestern Hospital on a renal med-surg floor and quickly transitioned to med-surg and neuro, where she spent 2.5 years. Donation has been part of her life for quite some time, and she really learned about LifeSource when she was a nursing assistant in the ICU back in South Dakota. So she's now been with LifeSource a year as an organ donation coordinator, and will be bringing that perspective to this conversation. Amy actually is a senior clinical resource supervisor at LifeSource. She's worked at LifeSource for 15 years. She initially did on-site referral management and family support. Currently, she supervises all clinical activity, with her focus being on referral and case management, which is not a small job, Amy. She, before that, worked as a paramedic. So I'm going to just hand it over to you, Sue, for your presentation, and I'll go off camera here as you present, and then we'll all come back for a robust conversation in a little bit. And please ensure everyone that's dialed in that you're putting your questions in your chat. We want this to be really interactive.
And Candy, please feel free if something's coming up in chat pertinent to what we're talking about. I have no problems with you interrupting me, so we can pause and talk about that. So
awesome. That sounds great. Thank you.
Good deal. Okay, so I'm going to get my PowerPoint going. There we have it. And before I get started, you've already met us, and this is who I am. This is my business that I run. Before we get started, I'm just going to give Amy and Maren a little heads up. I'm going to do a few slides, talk about some basic concepts, and then when I'm done, I'm going to open that conversation by turning to the both of you and asking you to comment about what what I've said that stands out to you or you think is most overlooked in the OPO world. So no dozing off while I'm talking. You better pay attention and have something to say. So great. So I'm going to start by just commenting that, of course, all jobs have stressors, or they wouldn't have to pay us to do our work, right? And getting along with coworkers and managers, working as a team, all those things are stressors that every job has. But OPO work involves some pretty unique stressors, and I want to just kind of go over them to begin with. And comment on the ones that I've noticed as sort of an outsider looking in. And I'll start with the physical stressors endured. That on-call shift work, disrupting sleeping, disrupting eating, and the long hours without breaks, certainly I see takes the toll on the fatigue of the OPO personnel, but also the adrenaline rush kind of gets into people's blood, that sort of high that you get when you're under pressure to work. And sometimes that repeated elevation and arousal can take, as we all know, can take a physical toll on people's well-being. There's mental stressors. So first and foremost, the information and overload, the amount of knowledge you guys have to carry and know and manipulate, along with the multitasking. Our brains were not created to multitask, so it's quite a stressful challenge in this work. And I would add, kind of along the lines of mental, is the high expectations that people hold of themselves and others. I've not met a group of people that I think held themselves to such high standards. And along with that is something I call mission suction, which is so much commitment to the mission that it's really, that's the first and foremost, and sometimes may even get in the way of people taking good care of themselves. Then there's the emotional, the exposure to just the emotionally intense situations without the skills training to regulate that emotional reaction. Always the pressure of saving lives. And somebody a couple weeks ago, I was interacting with another OPO, and they commented on the on-stage, off-stage, that sense that you have to have one face showing one emotion when you're forward-facing to the donor families or the donors or the hospital partners, when you might have something else going on backstage in your own heart and body. And then there's the social stressors, the shift work, which interferes with people's lives. You know, I was just asking Amy, do you get to have Christmas with your family this year? You're going to be working, those kinds of things. The stigma that I think still it pervades the community when people find out the work that you do. And then one particular social stressor that I'm struck with is the intense team loyalty that people have, but also the distress that comes along with very natural team friction. You're working under such pressured circumstances that it would be perfectly normal for human beings to have friction from time to time, but that in and of itself can be kind of stressful. And then finally, the last one is spirituality, but I don't mean religion here. I mean sort of the meaning of life kind of stuff. So, you know, the stress of a worldview that is impacted by seeing all the bad stuff. I mean, nobody shows up at an OPO and says, hey, look at me, my body's intact, and I'm just here to tell you that I'm living my life. You never get to see that part. The moral injury and moral distress, particularly these days, I'm hearing a lot more about registry opposition, those kinds of stressful situations. And then the sense of identity that people invest in their work, and how sometimes their job, it gets entwined in their identity, and they sometimes have some difficulty seeing themselves as a person first and a DC or an FSC later. So those are just sort of a summary of some of the kind of stressors that I see and I kind of look at every day as I'm working with OPOs. So I want to just take a couple of minutes and go over a few terms that you'll hear me using, and I want to be really clear about what I mean by these terms. And in doing so, I think it'll kind of direct your thinking towards some of the protective strategies that we want to talk about today. So let's start with stress. I operate with a kind of a different understanding of stress. Stress is like pain. It's a signal that should be triggering us to initiate adjustments, to ask what's wrong, and to figure out how we need to respond. Of course, stress is also an energy system, so it elicits in our body that energy to make the adjustments and to regulate. And I think that those signals that stress provides for us, the physical, the emotional, the mental, those things are really what tell us to begin to implement, are there to tell us to implement protective practices. But as this chart shows, stress isn't all bad. We wouldn't be getting out of bed in the morning if we didn't have a little bit of stress. But too much of it impacts not only our well-being, but peak performance. So we know from research that too much stress dampens down the prefrontal cortex in the brain, which is the thinking brain, as I kind of refer to it. And so under too much stress, attention narrows. We have a harder time seeing the big picture. We're more easily distracted, and it's more difficult to differentiate relevant information. We have some increased difficulty holding on to our working memory, so we might be more forgetful. Our complex thinking decreases, so we're slower at problem solving. Our cognitive biases emerge. Empathy declines. Small motor skills can sometimes decline under too much stress. And of course, then there's the team functioning. So our studies tell us that communication amongst teams in surgery situations, for example, will decrease as stress increases. And we'll see what the research calls rude behaviors, by which they mean short-tempered, blaming others, irritability, that sort of thing. So typically, in my experience working not only with OPOs but also with hospitals, healthcare workers have been taught to either overtly or covertly override their stress reactions. Just move on, just keep going, it's not your emergency, or sort of common phrases that I hear. And I don't think this has been very effective. If it had been effective, I wouldn't be here talking to you guys. We wouldn't have these high rates of burnout. So we need to really take a look, a different approach to stress. And we need healthcare workers to begin to learn the skills of regulating their stress in the same way they learn other technical skills. The other thing I want to say about stress is in the past, stress management has been talked about and thought of as something that we do after work. And this is what I call the chocolate cake and bubble bath strategy. But actually, that isn't what I define as self-care practices and stress management. What I'm talking about today are those small actions and behaviors that we can use while we're working. Things like behaviors, ways that we change our thinking, strategies and techniques that we use so that we keep our stress level regulated and balanced. And so that by the end of the day, we're not ending a shift with, or the end of the night perhaps, we're not ending a shift with a boulder of stress that we then take home to our families, but we've, throughout the time we've been working, tried to mitigate how we're being impacted. Another term that people have mentioned in their questions ahead of time is, or another topic that they wanted to hear more about, is burnout. So burnout has been included in the ICD-11 as an occupational phenomenon. It's not a medical condition. But burnout is triggered by an imbalance between organizational demands and expectations and the worker's ability to meet the demands. So it results from kind of a dance between the organization and the worker. And these are the three characteristics that we use to identify burnout: the emotional exhaustion or energy depletion, negative feelings or cynicism about one's job, and just a decrease in a sense of personal accomplishment or satisfaction with the work. And oftentimes professionals, when they notice these first signs of burnout, their instinctive response is to work harder, work longer, and that actually, we know from the research, exacerbates the burnout. So I just saw an interesting survey. This was not just healthcare workers, but all workers in general. They were talking about the Great Resignation, and in this survey they had identified that 40% of people that are resigning from their jobs these days are doing so because of burnout. So Christina Maslock of the University of California and her colleagues have done most of the research on burnout, and they have identified these 6 causes of burnout. And you can see that these are all organizational issues. And yet we still prescribe self-care as the cure for burnout. We sort of put the burden of solving the problem squarely on the shoulders of individual employees, and maybe even have a little bit of a blame the burnt out person for getting that way. But addressing burnout requires organizational effort, so the organization will need to take a look at some changes. But that being said, we are all professionals, and that means that we are skilled at working independently. And as professionals, we also have to take a look at and protect ourselves from burnout by learning some behavioral strategies. So another one that came up in the questions before this discussion today was compassion fatigue. And in reality, compassion fatigue is a misnomer. Really, it is what I would call it negative empathic strain, or straining for compassion. And here's why. Empathy, that feeling that you can feel somebody else's feelings, that is engages the pain network in our brains. And what happens then, well, so I'll give you an example. Imagine that you're watching somebody who gets a paper cut underneath their fingernail. And even as I describe it, you might wince a little bit, and you kind of know what that pain is. That's empathy. And what happens when our brains go to empathy is that we become very self-protective and very self-absorbed. So we're focusing more on protecting ourselves from the pain. Compassion, on the other hand, accesses a very different system of neural networks in our brain, and compassion is much more aligned with our motor system and with the reward center in our brain that gives us dopamine as a reward, helps us feel good. So we, as a skill, what I try to teach people is that you can feel the difference between empathy with a donor family, for example, and compassion. And compassion is really focused on understanding where they're at, but being in a position to take action on their behalf. So compassion includes a little bit more perspective taking and a little bit more focus on thinking and acting. And actually, we know from the research, and this is the research of Tanya Singer and Oma Kilmecki at the Max Planck Institute in Germany. They've done a ton of research on this, and what they know is we can teach skills of compassion. We can teach our workers to know how to engage compassionately instead of empathically, and this is another protective practice. All right, so another one that people raised is secondary traumatic stress. And I'm going to do another little exercise here to give you that experience, but I'm not going to traumatize you all. So take a look at that picture. You can see this big, juicy, cold lemon. And I'm going to pick this lemon up, and I'm going to take a great big bite out of it. And even as I say that, you might notice that maybe your lips are puckering a little bit, or you're salivating a little bit. This is an example of how secondary traumatic stress or vicarious trauma works. So what it really is it's the physical and emotional reaction to witnessing, but also reading the details of, seeing or hearing another person's trauma. And we know, again, from brain research that our brains can get activated, and we can experience a trauma almost as if it's happening to us. And what's particularly important, I think, to know in this work is that the symptoms of secondary traumatic stress can really mimic post-traumatic stress. And particularly what I've seen both in hospitals and in OPOs are people experiencing bad dreams or nightmares, images, situations where they can't stop, they say, replaying the video of something that happened, feeling guilty or responsible, and feeling more jumpy or more avoidant. And also having an experience that really changes how you view your world, seeing yourself as less safe in the world. So one of the things that we need to understand about secondary traumatic stress is the ability to acknowledge the somatic symptom, the reaction of the body when one's experienced this is the first step towards overcoming it. And it involves being able to put words to what happens. The minute we start putting words to that experience, our thinking brain takes over, and it can begin to move us away from that experience of somebody else's trauma and over to an ability to deal with it. So those are just a few really fast concepts that I've just kind of blown by you guys. And now I'm going to come out of my PowerPoint and invite Candy to come on if she wants to, and kind of turn to Maren and Amy. And one of the reasons I asked both of you to join is, Maren, you have critical care work from before, but you're new to the position, and Amy's is very seasoned. And so I think it brings two very different approaches that I'm anxious to hear about. I just wondered, as I was talking about these concepts, what stands out to you guys, either as the most important thing to note or the most overlooked thing in OPO work? And Candy, if you've got thoughts, please jump in.
I think the most overlooked and the most important thing are kind of hand in hand. So I think it's self-care, recognizing what we need for our own self-care, and when we're struggling as a coordinator, an FSC, an SRC, whatever our role is in that OPO clinically. And then also what's overlooked is organizations providing the resources for their staff on learning about promoting self-care and recognizing when they're starting to have an increase in stress or feeling that burnout feeling.
Mm-hmm. Amy, can I just pursue that a little bit more? What do you think makes it so hard for people to recognize when they're struggling?
I think in the OPO world and just in healthcare in general, we don't focus on ourselves. We focus on our patients and what our patients need and what their and what the families need, especially when we're working with donors and donor families, that our needs kind of become backseat, not really that important, when in reality, if we're not in a good place and able to manage our stress and function, we're really not actually helping that donor family or that donor at all. We could actually be causing more harm.
So really kind of teaching the value and the skill of holding both in mind. We don't have to be one or the other. We can do both. Mm-hmm. Yeah. Maren, what do you think?
Yeah, I think kind of similar to what Amy's saying, and being newer to the OPO world, I definitely overlooked my own self-care starting with this job, and kind of wanting to do the most and be the most involved, and making work a priority when I'm not working was huge for me, and kind of starting to recognize that I don't need to be paying attention to work emails today. I'm not on call. I don't need to be looking at the referral board when I'm not working. It came more out of a curiosity and a desire to learn the job better. But as I, kind of eased into that more, I got more used to being able to disconnect and take a step back and realize, that's work stuff. This is personal life, and kind of learning to separate the two. And I definitely overlooked that when I first started the job.
Candy, is there anything in chat or anything you want to add to this?
Yeah, there's actually a comment just came through, and the individual shared making sure we have enough staff, paying us enough that we don't feel the need to work overtime. Overhiring and having our directors and some administrators come into the field when we are short-staffed to help the front line. So more of a comment. I don't know if you have additional thoughts about that, Sue.
I do. I think that's, all of that is very true, is that systemically, this could be very controversial, but I'm going to say this anyway, because that's what makes conversation happen. I have noticed that in healthcare in general and OPOs in particular, I sometimes wonder, it seems as if the positions are created and developed in such a way that people can't stay in them for very long. These are jobs that require people to, their sleep is disrupted. I don't know how people with young children do this work because their life is so irregular. And I think that one thing is that that's really important is for the OPOs to take a look at what can they do to create jobs that are sustainable for people, where people can stay. So that's just a comment I have. But I don't know, Maren, Amy, do you guys have any thoughts about that, the staffing issue?
Yeah, I think for our OPO at least, when it's really busy, our, Amy's position, she's our clinical resource supervisor. They always are, doing a good job of trying to figure out what's going to be the plan for the rest of the day. I don't want my staff to be working 24 hours. I'm going to, put out for additional supplement is what we call it, to see if there's any interest for people that aren't on call that day to come in and work. So when you see that, I feel like it, you feel the support, and they recognize, we are really busy. We're going to see if we can get some help. I've seen my manager come in and work as a clinical resource supervisor, when we were short staffed there, and help with referral follow-ups. So you have to have that support from the organization as a whole, in order to feel the support.
Right, and I'm just gonna, I completely agree with all these structural discussions, and I also have found in the world of healthcare and OPO, we could spend the entire hour talking about how the system should change so that it's better for us. But that, the bottom line is we find ourselves at this point in time working in organizations that are short-staffed and having to step up. And I think that the challenge for the individual professional is to be very clear about their own limits, their own ability, and have that ability to say no, and not be, as Amy says, to just not pay attention. Because if you guys go down, the whole organ procurement goes down. And I think it's as important, it's protecting that resource and protecting yourself as a professional. I saw a comment about sleep. And I'm so glad somebody brought that up, because I have something to say about that. And it has to do with the 24-hour staffing schedules, which I think are really, really unmanageable. And in particular, I think it's really important to remember what happens to people when they're sleep deprived. And when they're sleep deprived, depending on how sleep deprived they are, they move into a state that's comparable to being under the influence of alcohol. So we don't have pilots flying when they're sleep deprived. We try to encourage people not to drive when they're sleep deprived. And what I mean by sleep deprived is 19 hours or more awake, if without sleep, that you're comparable to a 0.5% blood alcohol level. 24 hours, you're at a 0.1% blood alcohol level. And I've talked to people, staff who have been, 18 hours out and they still haven't slept. And all I can say to them is, we're not going to deal with the stress or anything else till we get you some sleep. Sleep is, if you want to drive somebody into mental illness, deprive them of sleep. That's the first thing that you do. So I'm a big fan, and my wish, if I had a magic wand and I could get Iron Man the world and I could get the OPOs to do anything, I would have them create sleep policies for the organization. And I would have them insist on limiting scheduled work, no more than 12 hours a day ideally, but at minimum no more than 16 hours consecutive, and at least 11 consecutive hours of rest provided every 24 hours. And I think that they should limit the number of hours that people can work during a week, limited to 60 at most, and not be permitted to work more than 80 hours a week. So those are things that I feel, if we want to really tackle this issue of burnout, the first step in my book is we need to tackle the shifts and the sleep that people are struggling with. Until those things are addressed, we're going to have people burning out. So now argue with me, people. Amy, Marin, Candy, people in the audience, go for it. Throw the tomatoes now, any of you that are managers or leaders.
We have a lot of additional questions that kind of fall in to that, Sue. One of them is, how do we learn to recognize when self-care isn't enough and you potentially need more or different treatment?
Okay, so I think that they might be, let me clarify, are they talking about the difference between stress and self-care and when you tip over into mental health issues? Okay.
I believe so.
Okay, so what I'll say about that is, well, first and foremost, we need to be training our staff to recognize signals of stress. What are their personal signals of stress? And to keep those forefront in their mind as they work. Because that in and of itself is going to be preventive. If I say to myself, oh, look, my stomach just clenched, that's telling me I'm having a stress response. Let me pause for a minute and get myself re-regulated before I go forward. That's going to go a long way. And I really want to differentiate between stress and mental health. Okay, mental health or mental illness, really, when we talk about depression, when we talk about anxiety, PTSD, those are injuries and illnesses that need to be treated. And there's very specific criteria, but typically it has to do with having, disrupted mood, disrupted sleep, for at least 2 to 4 weeks, so over an extended period of time. And stress is typically something where you feel like your socks have been knocked off and you feel terrible. And when you can get some sleep and when you get some time to use some of those personal protective practices, you can kind of regroup. Now, there's this middle gray area that we call cumulative stress that a lot of people are talking about right now during these times of COVID, when they have to keep going and going and going. And there's also, and that's when we get a little bit more, it's really important to be able to stop and say, how long have I been stressed? How much is this disrupting my work? So it's very clear that if you're having trouble doing your job, you've fallen into the category of illness or injury, anxiety, depression, PTSD, whatever, right? So when you have impairment, that's when you see that dysfunction. When you're struggling, when you're having a hard time, but when you're able to realize, I'm really feeling like low energy, I'm feeling disillusioned, there's some things that you can do, I can get some help. That's more the acute and cumulative stress, if that makes sense. But Marin and Amy, you guys have probably seen some things, and I wonder if you have stuff to add to that. Or not.
For me personally, I can see where I start to hit my tipping point is when I can't make a decision. Like I can't even pick what shoes I'm going to put on my feet, or something very simple, or I struggle to make a decision that I make 1,000 times in my workday. I lose all sense of concentration.
There's that cognitive impairment you're talking about. Yep.
Mm-hmm. And then when I know that I've had my limit and I need to tap out and take a break, I feel myself just getting like angry and short fused, and everything kind of becomes a competition. Like we're like, well, I understand that you're tired, but I'm tired too. So you kind of just hit that point where you almost get a little spiteful. And for me, that's my point where I'm like, I have to take a day. I just need to unplug. I need to walk away for a little bit.
And that's an example of the fight response in the fight or flight stress response. And that's very typical. So when you see that, now if Amy couldn't figure out what shoes to put on, she couldn't make up her mind about what shoes to put on for 2 weeks in a row, I would say, Amy, you've tipped over into a whole other realm that needs another discussion here. But at the end of a shift, in the middle of shifts, very stressful, to have difficulty making decisions is a common cognitive signal of stress. I'm wondering, you guys, both Amy and Marin, if you might speak for a minute to any of the personal protective strategies that you either used or learned while you've been working at LifeSource. Let's have some of your personal favorites.
I feel like something really big for me with kind of working like alone a lot of times on site, like yes, you have the hospital staff there with you, but when you're the representation for your company there by yourself, it gets a little lonely. And so I think things that I've tried to develop as like good practice are, if I'm feeling really overwhelmed or anxious about my workday, is stepping completely away from the space that I'm working in and going for a short walk. Obviously in Minnesota, it's very cold right now, but I try to go outside if I can as well, just to get some fresh air and completely step away from what I'm doing. And then when I'm not on call, completely disconnecting, like not having my work phone on at all or silencing it, trying not to check emails that are work related during that time. And yeah, the disconnect is really big. Not thinking about work when you don't need to.
Right. And there's actually a lot of research about, 3 or 4 different strategies that people can engage in their off hours that will help them rejuvenate so that they can go back to work. And it involves, some common sense things like just letting go of responsibilities and giving yourself some time to kind of lay back. Unplugging from work is number one. Giving yourself some sort of physical relaxation, being a couch potato for a little bit of time. But another really interesting thing is having an activity that is mentally absorbing to you, so that when you're off work, your mind gets focused on something else. And it may be, a hobby, or it may be, I don't know, people talk about jigsaw puzzles or anything that's just going to let your mind not be kind of churning and thinking, but really give it a break and focus someplace else. So that's really good. Amy, what about you for coping strategies?
So I echo Marin. I do not look at our referral board. I do not look at work stuff when I'm not at work. I've set some pretty strict boundaries where I have 2 days a week where even if I'm not on PTO, I'm not going to carry my phone or check in on it. Um, when I do go on PTO, I completely shut my work phone off and I block every colleague I work with from my personal phone so that I'm truly unavailable for up to a week or 2 weeks. That's just my way of kind of recentering myself and reconnecting with my family, because we all know doing this type of work when we're on, we're focused on working and our focus is right there.
Mhm.
Um, I also make a point to kind of get up every couple hours from my desk, walk around, maybe go have a conversation with somebody I normally wouldn't have a conversation with. So, um, and check in on see, how their day's going or ask about their kids or family or pets. And then I listen to music when I'm working, when I'm not on the phone. So when I'm just doing, data entry or EMR reviews or whatever I'm working on, I usually will have some type of music going in my ear or in the background.
I love that. And I just want to emphasize one of the things that Amy's talking about. The research is telling us that about every 90 minutes, if you can give yourself a break, and I'm not talking like 15 minutes or something, I'm talking 3 minutes to let your mind wander to something more pleasant. I love that you talk to people about their kids and their dogs, because what does that do? That elicits oxytocin, which is the calming neurochemical in our brain. So that's a great way to refresh. Getting a drink of water, stretching, walking, those even 3 minutes on a regular basis throughout a shift is going to go a long way to keeping you, at that top of that stress pyramid that I showed, not going too far one way, not going too far the other way. Some of the other things that I work with when I do trainings that I work with staff on are attending to how you're starting your shift, and in particular, what are you saying to yourself as you get ready to start your shift, either as you log on or as you go into the building if you're working on site. Notice what you're saying to yourself. Oftentimes these days in times of COVID, people are saying things like, I'm walking into a war zone, or those kinds of things. Well, actually, you're not walking into a war zone. And to say that to yourself, what happens? Our thoughts are the operating instructions that we send to our brains. So, what happens when you say that to yourself is you're starting your shift by increasing the adrenaline, the cortisol, before you've even hit the ground running. So, being attentive to what you want to say to yourself as you go in and how you start your shift. And likewise, what do you do at the end of the shift to let it go? And one of the things I really work hard with people, this is a good research-based strategy. Many of you probably know it. 3 good things. At the end of your shift, before you go home to your family, your loved ones, your dog, your goldfish, whoever it is that makes meaning in your life, you want to pause and say, what are 3 things that I did today that I'm proud of, that I accomplished? They don't have to be dramatic. You don't have to change the world. Some days for me, it's like I was able to walk across the room without tripping on my feet. There's a success, something little. But every time we do that, we elicit a little hit of dopamine, a little of the reward neurohormone that helps us feel happier and better and more productive. So there's a lot of things we can do with our thoughts that we need to train ourselves, because y'all didn't get trained that when you were in nursing school or being trained as RTs or whatever, and our community doesn't train people. But these are some of the strategies that we need to use. I don't during the I have a protocol I've taught some of the people at LifeSource, reset return, which is 2 minutes of just going through a little protocol to reset your nervous system. So there's a lot of these different, very small personal protective practices that can be utilized through the day that help people keep themselves regulated. So I'm going to stop talking for a minute and see who else has questions, thoughts, comments.
I'm going to summarize a little bit because we're really lucky to have a really engaged group, an audience here. So there are lots of comments about 24-hour shifts. I think some are questions and some are comments about it being the root of burnout or one of the causes of burnout. There's also kind of a related comment about making sure organizational culture is one that promotes coming forward when you're feeling burnt out, creating a safe space to discuss concerns and not feel like it could be used against you.
And can I just make a comment about that?
Yeah, please.
Burnout, what happens to us when we've overextended ourselves is a physical injury. It's an injury to our nervous system and an injury to our brain. If you were coming forward to your leadership and said, you know, I sprained my ankle when I was working on this, or I got stuck by a needle, there would be no second thoughts about speaking up about it, and no second thoughts about the attention we would pay to recovering from this. And I think we really need to confront this stigma and say to ourselves, stress is no different than other physical injuries. And that's another way that we can make it be safer in a culture, in an organizational culture, to be able to speak about this. Sorry, go ahead, Candy.
Oh, no, that's great. And do you want to speak a little bit about debriefings after
Yes.
really challenging cases? Because while you do that, I have about 12 more comments that I'm going to review, and I'll be back. But I think that's a really important part of this conversation.
Okay, I'm actually going to, I think, go to a slide about debriefings. Well, I don't think so. I think I'll just skip it and talk about it. So what's a debriefing? Some of you may know that word is a horrendous process that you go through when somebody's screwed up. I'm not talking about those kinds of debriefings. I'm talking about, I prefer to maybe call them a de-stress discussion or a stress debriefing. So this is an intervention, not even an intervention, this is a strategy that we can use to help people process difficult cases. So what does it entail? It's about a 45-minute to an hour conversation, can be individual or with peers that worked on the case, and it's really an opportunity to take a deep breath, to step back, to kind of get a perspective, to evaluate, how is this case hitting me? How's it landing with me? How is it impacting me? And how is it impacting my sense of myself as a professional? How is it impacting my feelings about my organization? And how is it impacting my well-being? So I feel really strongly that these de-stress discussions should be led by somebody outside of the organization. They definitely should not be led by leaders or managers, because those are people that have power, and people aren't going to be comfortable. You can be the most wonderful manager in the world, and I'm sure you all are, but people are just not going to be comfortable talking about some of these things with the person that maybe will be evaluating them, or giving them salary increases or whatever. I also think that I'm well aware that you all do a wonderful job of being great peer supporters to each other. You debrief all the time with each other in difficult cases. You're texting, you're calling, you're chatting. All of that is great. But a de-stress discussion gives you the opportunity to have an outside person come in and ask you some questions that you would never think to ask yourselves, because you all drink the same water, live in the same, have the same Kool-Aid, live in the same culture. You wouldn't even think to ask it. So it's really an opportunity, and you don't even have to be a basket case to do one of these de-stress discussions. If one of these cases just sort of sticks to you, it's like, I've been thinking about this one. It's a great opportunity to step back, have this discussion, and really just take a toll of, how am I doing? It's just another way to kind of take a look at burnout and compassion fatigue and all that other stuff. So is that making sense? And Maren and Amy, would you guys add anything? Or Candy, or anybody in the audience? Any comments are welcome.
Yeah, I'm a big fan of that approach, because I think our work changes us, and having an opportunity to actually work with a small group and someone outside your leadership team to have these conversations can be really, I feel like, effective and healing. There's some comments too about one of the organizations has a trauma stewardship program that allows employees to track and incentivize them for like physical, emotional, mental health, self-care time, which is awesome. And there are a lot of comments about, I think, kind of the culture and concern around, if people are working on resiliency, or they're feeling burnt out, that there's a stigma attached to someone thinking that they're being lazy. I see a comment, lazy or unmotivated or stuck. If you're in a situation where you do need some time, that you do need to, set some boundaries and take some time. So I don't know if any of you have comments about of any of those comments that are coming up in chat.
Well, I would just say that, yes, I've seen different organizations where there is stigma about burnout. And I think that that's really a organizational, something the organization needs to work on. I think particularly in these times of COVID, in this day and age, when people are leaving we can't afford to have people who are as highly trained as you all leave because of burnout, and it isn't even necessary. So we really need to turn it around and begin to stop making moral judgments about people, about all of us. I mean, I think that's one step. I love the person that was raising the incentivizing for self-care. I mean, I think that's a great way to change a culture. And I would just add, every year, every organization has their employees set goals for themselves. And I think it should be a requirement that a stress management goal be set, and that the employees should document and prove how they have addressed that. Because we are losing people because of stress and burnout. And if that's of concern to us, if we're understaffed, this is one of the things that we can do to turn that around. You can see I get a little passionate about this sort of thing.
I love that. I think there's an irony that OPO work is based around, the altruism of families, and we're so good at taking care of grieving families and healthcare teams. And I think there's some irony in that. We need to put that same level of effort, and I know many OPOs are into resiliency programs.
Yes.
And into having it be part of our culture, not an option, but really being something that we do to ensure that we're a healthy organization with healthy people working with families.
Mm-hmm. Other comments from you, Maren and Amy, or Candy in the chat?
I'll let Maren and Amy have a moment here, and then I have a few more chats if you don't have additional comments.
Okay. Amy, Maren, what are you guys thinking as we're talking about this? What do you think maybe is one of the areas that we could do some improving on?
I think some improvement too would be training for the leadership staff at the OPOs to kind of see, to be able to pinpoint maybe some behaviors where they can earlier identify when people are starting to struggle. I know here at LifeSource, so my team, the CRS team, we work hand in hand with our clinical staff. We deploy our clinical staff. We are usually the ones that elevate it up to leadership, where we're starting to see people they're struggling, or we've had really bad cases, or like once we had a run, I think we did 12 peds in a week. So when we start seeing these trends where we'll cue Sue in, like, we need to pull together. The team is more likely to come to my group and have these conversations than they are with leadership, I think, with management, because we're in the trenches with them. We're working with them. Even though we have supervisor in our title, we don't supervise staff, we supervise activities. So we went through some training to identify some of those signs and a little bit earlier on.
Mm-hmm. Mm-hmm. Yeah.
One of the additional comments relates to, which I can relate to, a large DSA. This individual is talking about being able to retain staff and allow us to travel within our own regions would certainly help with fatigue, rather than having people travel as far a distance. I'm assuming this is case related. Let's see. I can't stress enough, retention is a huge issue in our work, and we're expected to do more all of the time.
Right. And I just think, to kind of go back to it again, if we structure jobs, let me speak a little bit about the mission. I've never met a group of people that are more mission driven than people in the OPO world. You know how strongly everybody believes in what the work that you do in saving your lives. And it's really admirable. And as all good things, it's got a dark side. And I think the dark side of the mission is that it's sometimes becomes the justification for driving people to work beyond their means. You know, we're saving lives, we've got this to do, and so people should do more, and that sort of thing. And I just don't think it's any more possible for people to do any more than they're already doing. And we need to, if we're worried about retention, then we need to structure the jobs so that they're not burnout jobs, so that they're jobs that can be managed by people with families and managed by people who need sleep. And you know, we've seen the research about what happens when people work too many hours and they're sleep deprived. We've seen the errors that occur in the medical setting. We know this information. So we need to make, these are some of the structural changes. And I mean, I'm along with you. The transportation, that's a really thorny issue. How do you get out there? How do you get around? It is very draining on people to have to do that traveling, and again, sleep disruptive as well. So there's some very thorny organizational issues that need to be grappled with. But what seems so clear to me is that if retention is of concern to people, then the first step would be to structure these jobs in ways that are more sustainable.
There's a comment too, which I think you started by asking Amy about the holiday. Are you working Christmas? And I think those of us that have worked in, this line of work know that there are some holidays, right? But there is a comment about on holidays too, there can be peaks of activity, like surges of activity around the holidays. And how do we as an industry staff for those times too? Because it's hard to know, right, when you're going to be really busy, but especially in and around the holidays.
Right. That's a really very good point. And I think the holidays take an extra emotional toll on staff, not only because they can't be doing the rhythms of life that keep us going, our holidays and things like that. So that human nature is such that we want to do that. But beyond that, I am always struck with how many debriefings, de-stress discussions I do around the times of the holidays, because these are more poignant for everybody. Our empathy gets triggered more easily, and I need to work harder to get everybody to tip into compassionate care at times of the holiday. And we could do a whole other session on empathy and compassion and how you switch back and forth, because I think it's a rich area of skill training, but that's for another time.
There were comments about that actually, Sue, about kind of that differentiation and that interest in hearing more.
Yes, yeah. So.
I think we have like 8 minutes left. I don't know if there's anything specific, Sue or Miriam or Amy, that you want to make sure that we're communicating as we're coming to the end of this session.
For me, the most important point that I would like to get across is that I'm advocating for a change of attitude about stress, and to understand that stress, we can train people in personal protective practices. We can train them to use them in the same way we've trained them to mask up and gown up. And that we should be doing this training as much as we do technical training for how to do technical procedures. It should just be one more skill that employees are expected to be able to master. And that is I use compassion and empathy today as one example of the kinds of things that we can train people in, but we can train people in the protocols for rebalancing the nervous system. We can train people in how to manage professional grief. We can train people in the strategies and techniques for letting go of things, of cases that we're ruminating about or that are bothering us. Each and every one of these topics has specific skills that we can train people in, and we could put it right alongside all the other skills training you do. So that's my thing. How about Amy and Maren? Do you guys have any last points that you think you'd make?
I guess I would say, don't feel guilty if the answer is just no, that you can't pick up and do extra. Don't feel guilty about it. And the responsibility that we have as clinicians is to show up and do the job as we can, when we're scheduled, what we can give a little bit extra, but it's not our responsibility by ourselves to work every donor that our OPO sees every year and to run ourselves into the ground. So don't feel guilty. Sometimes the right answer in the moment is I need to take care of me or my family, and that's what I can give you today, because otherwise I can't give you tomorrow.
Well said, Amy.
I think the biggest thing is just take care of yourself at the end of the day. Like Amy said, we can't do this work if we're not ourselves. And whether that's drinking water, remembering to drink water, getting 8 hours of sleep at night, speaking up when you aren't, in a place to be able to function at the highest capacity. And to remember to appreciate your coworkers and say thank you whenever you can, because you never know how far that's going to go for them. I know it goes a long way with me.
And at the risk of being a brain nerd again, saying thank you, gratitude, being kind really does adjust our nervous system. That's my basic practice when I'm having a bad day. Is I go to the grocery store and I'm nice to the people in the grocery store, and it helps change my mood. So, yeah.
I think we'll have one more question, a comment that I think is an important one. And there were several that kind of attached to it. Is there was a comment about at this person's OPO, they talk about 3 years being the lifespan of an organ recovery coordinator or organ donation coordinator. And I think that's just one of, or it could be, a donation and family advocate, multiple positions, but that just in itself is really challenging.
Yes.
To be able to have that out there. And then there were many comments about how long folks have remained in their work or that they've transitioned. One person mentioned transitioning to the transplant side. And I think I just wondered what your thoughts, Sue, are about that, about this kind of unwritten rule about 18 months or 3 years or whatever time frame it is for these positions, and our responsibility as organizations to create sustainable rules and resiliency programs and empower people to have healthy boundaries.
Right. I think given the amount of training that goes into any of these specific roles, 18 months, 2 years, 3 years, I can't believe it. That's like nothing. I mean, that's a very expensive turnover rate. And I think that, when we look very seriously at it, why are people leaving? It is because of burnout and resilience issues, and we can do something about that. So the thing I always struggle with is that people go into the job saying, well, this is a job that I'm going to be in for 2 years because it's so high burnout, and then I'll move on. So are we, also creating our own reality by our expectations? So those are just some of the things that I think about.
That's great. And I see other comments of folks that have been in their roles for like 10 years and 12 years. And some of them saying, I'm tired.
Right.
Do you have any, I mean, we literally have 3 minutes. Do you have any like comments for those folks that have been doing this work a long time?
So I'm tired is such a statement that I hear all the time. And I think you have to tease out, I'm tired, why? I'm tired because I'm not sleeping well. Okay, let's deal with sleep. There are strategies to help people even if you work shift. Okay? I'm tired because I'm emotionally tired. I'm tired of carrying the weight of all these sad cases. We can do things about that too. Emotional tiredness has results. There's lots of strategies we can do. I'm tired because I'm not interested or stimulated in my job anymore. Then we need to add some excitement to the work. So when we say I'm tired, you really need to tease out what kind of tired. And once you figure that out, there's many different pathways that you can go down to address that I'm tired thing.
That's awesome. Well, thank you. I'm going to close us out. We have 2 minutes. I have to say, I don't know that I've seen this many great comments and actually communication between folks that are actually dialed in together, saying hello to each other in kind of this community. So thank you, Sue, Maren, and Amy. I think this is such an important conversation and one that I think we all have a responsibility to take back to our organizations to be able to ensure that we're contributing to this as we move forward. So thank you very much. Anyone that had additional questions that are in the comments that we didn't answer, we'll make sure that we're collecting those and we'll be getting back to you. And the slides will be sent out, and this is also recorded for any of your colleagues that weren't able to attend today. So thank you all very, very much. And Deanna, I know that you will close everything up for us. Thank you. I think we can all dial out now.
Okay.
Thank you
Thanks.
so much. Thanks you all.
Thank